Recording in progress.
Well, hello and welcome, everyone. Good evening on the eastern part of the United States for those of you, but thank you for joining us from worldwide. Welcome to our webinar tonight on terrible triad injuries of the elbow. I want to thank our chair of the Hand Education Committee, Marco Rizzo from Mayo Clinic. I'm Jeff Lawton, a hand upper extremity surgeon at the University of Michigan. I'm joined by a great cast, John Capo, my colleague from Rutgers in New Jersey, Nikki Zelenski, hand and upper extremity surgeon at Emory in Atlanta, and Will Aibinder, my partner, shoulder elbow surgeon at the University of Michigan. I also want to thank Mackenzie and Abby from AO for all the help in putting this together. All of our financial conflicts of interest potentially have been mitigated, as you see here. For those of you who are interested in CME credit, there is a mechanism by which you'll be able to get CME credit, and a link will be sent to you 24 hours after the event. In terms of content validation, AO is an independent nonprofit surgical specialty society dedicated to the improvement of patient care with musculoskeletal injuries. We do not endorse any specific product. You will see various products. We're going to try to talk about them in generic terms, and we're talking about concepts. We're not talking about how to use a specific society dedicated to, and the goal is teaching and education. I do want to, though, give a shout out for some other upcoming educational opportunities in this coming year. In February, acute scaphoid fractures. These are all webinars. In May, a finger flap webinar. In August, both bone forearm fracture that I'm hosting, and then in December, a webinar on distal radius malunion. So those are our web offerings. In terms of our in-person events, there's two hand and wrist fracture management regional courses, one in Irvine, California, and one in Jersey City, hosted by John Capo. And then there's two in-person opportunities, both cadaveric courses, one in San Diego in late May, early June, and then the other in Florida in mid-November. So just a little bit of Zoom etiquette. All of our participants' microphones have been turned off, but that doesn't mean we don't want to hear from you. We would appreciate your questions, and you'll send them through the QA. Our panelists will answer some of them, and depending on time available, may answer some live. And then we'll use the chat just for our the panel's purposes. So if you would use the QA if you have any questions. Overall, this webinar discusses ligamentous and skeletal anatomy of the elbow terrible triad injuries, treatment options for each component, role of various adjunctive treatments that we'll discuss, obviously possible complications, and then the implications for therapy and rehab to get our patients back to function. So we have objectives, and there will be objectives for each segment, but overall identify ligamentous and skeletal anatomy as it relates to these injuries, recognize the mechanism, direct the evaluation beyond plain films, identify indications and procedures, operative management of each component, and then to think about the rehab as it applies. This is an overview of how things will be broken down. And we'll get started with the intro. So the objectives Overall, develop a method to critically evaluate and manage terrible triad injuries of the elbow. Be able to employ an algorithm, and you'll see throughout a couple of these talks that we're talking about the individual components and the various steps along the decision-making in an algorithmic fashion, and then to gain knowledge of specific surgical treatments and rehabilitation programs. So overall, elbow dislocations are common. In many places that you read, they're secondary only to shoulder dislocations. However, as a hand surgeon, I would actually think that PIP dislocations are more common, but that's neither here nor there. Anyway, elbow dislocations are common, 6 per 100,000 in a Swedish population study. It's important to understand that a terrible triad injury isn't necessarily a larger energy injury than a simple elbow dislocation. However, the results are far more compromised, as you'll see. And as always, the elbow has the goal of stability versus motion, and those two are in conflict. So we haven't always known about this. You know, depending on your age, you may have grown up and we've always known about it. But, you know, for the last 30 years or so, we have. Bob Hotchkiss initially described these challenging injuries, including a medial ligament disruption, radial head fracture, coronoid fracture. Treatment included direct repair of both the MCL and the LCL, with concomitant management of the coronoid and radial head. And he noted, rarely do we excise the radial head. And that's a truism that you'll hear. And then Ring and Jupiter had a small series of 11 dislocations. And they noted with the radial head and the coronoid fracture, with pretty modest follow-up at 2 years, patients weren't doing as well as one might have thought. And this was a little bit of a hodgepodge of different treatments. But what they found overall is that when there was radial head resection, they sort of did poorly, and they had a significant rate of redislocation and reoperation. Again, you see a 90-degree arc of flexion extension. And in the end, they recommended radial head repair or replacement, LCL repair, and coronoid fixation. And that's the basis for a lot of what we do still out of this early study 20 years ago. So terrible triad injury in general, as many of you know, is a dislocation of the ulnohumeral joint, fracture of the radial head, and fracture of the coronoid. And when it presents with an x-ray like this, it's pretty straightforward. But the important thing is pattern recognition. And I think that's a really important theme, because you have to recognize it when it shows up in your office, like this picture on the right, and it may be more subtle. So again, if you look at the individual pieces, and I don't really like bacon, lettuce, and tomato sandwich, but I'm using this as a metaphor. So if you think about a BLT sandwich, we're going to sort of deconstruct it and talk individually about treatment of the radial head, treatment of the coronoid fracture, and treatment of the ligamentous structures of the elbow. So we're going to sort of deconstruct, treat it piece by piece, and then that'll give us an opportunity to visit some issues of supplemental stability, and then look at and work through some cases. So this is a 47-year-old retired female professional football player. We had the Cleveland Fusion where I practiced for a decade. So this was a middle-aged woman, but still very active, who had this elbow injury, was reduced and casted for 3 weeks. And the treating orthopedist called me and said, it just doesn't look right. So I saw her in the office, and sure enough, he was right. It didn't look right. As you see on this x-ray, so there's persistent subluxation of the ulnar trochlear joint, as you see here. So with this as a framework, so what do we do when we see this? So I am going to hand over to Nikki Zelenski, who's going to talk about our first component, which is the ligamentous and the capsular stabilizers. Thanks, Nikki.
Great. Thanks so much. Can everyone hear me okay?
You're good.
Perfect. Yep. So these are our learning objectives. We'll talk about the stabilizers of the elbow, review the mechanisms of injury. Like Dr. Lawton mentioned, we'll talk about key indicators of instability patterns. We'll review the techniques for the treatment of the soft tissue parts of the injury. And then I just want to talk a little bit to you guys about some backup options. Primary stabilizer of the elbow is the ulnohumeral joint, including the coronoid, as well as the MCL and the LUCL complex. Secondary stabilizers include the radiocapitellar joint, the capsule, and then there are dynamic stabilizers, including the flexor and extensor tendons as well. The MCL and radial head are the primary restraint to valgus force, the LCL and coronoid. The medial part of the coronoid here are the primary restraint to varus force, and the base of the coronoid and the radial head are that primary restraint to the posterior instability. We're talking about terrible triad. We're talking about valgus posterior lateral rotatory instability. This occurs with axial compression on the forearm, with the forearm in supination and valgus. You can see the supination, the radiocapitellar joint dislocates, and then ultimately the ulnohumeral joint dislocates. The force starts here on the lateral side of the elbow, and then tears through the ligamentous structures in the soft tissue, both posterior and anteriorly around to the medial side of the elbow in a sequential manner. Like Dr. Lawton mentioned, there's some key indicators for terrible triads that are easy to see in this X-ray: radial head fracture, a coronoid fracture, and then the elbow dislocation. But like he mentioned, when they walk into your office or even the ED reduced like this, it's often difficult to differentiate these from just a radial head fracture or a simple elbow dislocation. So your spidey sense has to be really high when you see something that you might be suspicious is something more than just a fracture or a simple dislocation. And you can again see the hallmark features on these images with the radial head and the coronoid and the subluxation of the joint. I did want to mention varus posterior medial rotatory instability, which is not the classic terrible triad, but it's still really important for everyone to be aware of. This is from varus force with the arm typically in pronation and axial compression. And this also has its own typical pattern. So this causes an anterior medial coronoid facet fracture, which you can see here. And this is a pretty big one, but sometimes they're smaller, and you might be tempted to treat this non-operatively. But the problem is that there's also typically a rupture of the LUCL. And although this usually walks in reduced, you don't often see these completely dislocated. This pattern, you really have to have that spidey sense high that something more is going on here. And that's important. You can see it here best probably on this 3D view, that this is that same case. You can see the lateral joint is gapped open and the humerus is impacting into the medial facet of the ulna. It's very important to recognize and treat these, because if you don't, these lead to chronic and early degenerative arthritis of the elbow. They're approached a little bit differently under a different algorithm. I typically do a medial approach for these and fix the facet. And then I stress the elbow to see if I need to go laterally and fix the lateral ligament. This is how I stress the elbow. Essentially, so you put it in varus stress and see if it gaps laterally. And then also on a perfect lateral, just arrange the elbow into full extension. And if the ulnohumeral joint dislocates, then you'll have to go laterally. So if we go back just to the classic terrible triad that we've been talking about, the radial head, the coronoid, the elbow dislocation, do these all have to be treated with surgery? Well, not necessarily, but you do have to treat them all. If they meet a certain criteria, which are listed here, we can treat them with an early protected active range of motion protocol, which we'll talk a little bit about later. But you're not just treating these in a cast or a splint or a sling. They need a special therapy to treat the ligamentous and bony injury while keeping the joint reduced. Typically, we do treat these surgically. And there is a good, pretty well-published algorithm. If maybe one of our other moderators wants to put the paper into the Q&A or into the chat, so our attendees have it. But the first thing I'm always thinking about is, do I need to fix the coronoid, and how am I going to get there? Then we have to decide if the radial head is fixable or not, which one of the other speakers will talk about later. If the radial head is not fixable and you can resect it, it's much easier to get to the coronoid. If it is fixable and you can't fix it, you can still get to the coronoid from lateral. You do have to do a more extensive release, but you also might have to go medial just to get to your coronoid fragment. But ultimately, you have to address the radial head and the coronoid fractures to regain your bony stability before you turn to fixing the ligaments. So let's talk about the LUCL and the extensors. So this is that same case that I presented earlier. You see that we've fixed the radial head in this situation. We've regained our bony stability. But this is an example of what happens if you don't fix the LUCL. You can see that in supination, which is the position of most instability, it dislocates, but even in pronation, this elbow is not stable. So we're looking at the perfect lateral here, or almost perfect lateral, in extension to see if the ulnohumeral joint stays reduced or not. And here you can see it does not. After we repair the LUCL with an all-suture anchor, you can see that the ulnohumeral joint stays reduced in full extension in neutral supination and pronation. This is how I do that. This is how I do the repair with an anchor. The anchor goes in the isometric point of the lateral epicondyle of the humerus. I then use a non-absorbable braided suture. I run down the LUCL complex. So this is through a Coker approach. So this is anconeus and then ECU. So a limb runs down the LUCL complex, and then I run back up and I close down the annular and any stretched out LUCL. I use an anchor. I find it easiest to use an anchor that has a sliding suture, so you can really bring that LUCL complex up to the isometric point. This can also be done through drill tunnels if you don't have access to or don't want to pay for a suture anchor with equivalent results and a similar technique. So after we fix the lateral side, we have to decide what to do next. And this is typically when we're deciding if we need to fix the MCL and go medial. There are a couple ways to do this. One is to use a suture anchor. So the origin, the MCL, is not here on the epicondyle. It's actually here kind of in this axilla, which is important to note. You can also use a brace if there's attenuation of the MCL. But again, we're really wondering at this point is when you need to repair the MCL. Go medial and repair the MCL complex. So here's another case of mine. So I obviously replaced the radial head. I've already fixed the LUCL. And you can see that there's gapping on the medial side of the elbow to valgus force. And even at 90 degrees, there is subluxation of the ulnohumeral joint. So if we could put up a quick poll, I did say the next step is to go medial and fix the MCL, but let's pretend I didn't say that because that's not the only answer. So if people could maybe choose what they would do. So go medial, fix the MCL, which is a classic algorithm, put an IJS in or an internal joint stabilizer, maybe put a X-fix on, a dynamic X-fix, or would you cross pin the joint? So while people are filling out the poll, Dr. Lawton, what would you do in this situation?
Yeah, so it wouldn't let me take your poll, but I would, while I respect your decision to fix the medial collateral ligament, I would put an X-fix on.
Ooh, nice, very good. How about one of our other panelists, Dr. Is it Aibinder? I'm sorry.
Yeah. So I'd do what you would do. I'd go medial to fix the ligament first, and if that's not stable after that, then proceed to the X-fix.
Yeah, I think that's the classic approach here. Is the poll visible for everyone? Most people decided to go medial.
I was going to say you were persuasive, Nikki.
Yes, I was. Excellent. All right, so that's what I did. There we go. So I went medial. I'll show you guys how I did it in just a second. I fixed the MCL, and you can see it's stable both to valgus stress and in full extension, which is great. So this is how I do it, which is through a Hotchkiss over-the-top approach, which is originally described as just anterior to the FCU, which is exactly how I do it. So here you can see this is the FCU on the behind the weedy here. This is the medial epicondyle, the sublime tubercle, and of course here's the anterior band of the MCL, which is the part of the MCL that you need to address here. This is a much more extensive approach than in this cadaver than I would use just for an MCL repair. So, for example, if I needed to get to the tip of the coronoid or the base of the coronoid here. I do want to note that it's very tempting to put your Wheatie on if you have a self-retainer, on this part of the FCU, but that ulnar nerve is very unprotected and very vulnerable. So I usually do dissect it out and make sure that my self-retainer is not pulling on the ulnar nerve. So unlike the lateral complex, the MCL can rupture from the humerus, the ulna, or have an intrasubstance rupture or attenuation. And so there are a number of ways to fix it, and you just have to kind of fix it from where it's broken, so to speak. So if it's avulsed off the humerus, it gets a suture anchor. If it's an intrasubstance tear, it gets a braided non-absorbable suture. And I actually do use this internal brace complex because I find a lot of these are attenuated and they don't repair very well. And those are the cases that I use the internal brace in or equivalent. So at this point, after we've fixed the bony stabilizers, we fixed the lateral side, we fixed the medial side. Traditionally, if your elbow is still not stable as assessed on that lateral x-ray, this is when we would do either an X-fix or an IJS. This is a beautiful example of a dynamic X-fix. You can see the hinge here at the isometric point. This is a case of Dr. Lawton's. I have not done this. This is not part of my education. I tend to use an IJS in these situations, which I've had a pretty good success for. I think the IJS is pretty nifty. There are a couple other uses or other ways I use it in my practice. So here's an example. This is a 30-year-old. He fell 30 feet. He had a bad TBI as well as a bunch of lower extremity fractures. He'd been in the hospital for a week or so, and he's taken his splint off probably about 3 times at this point and dislocated his elbow every time. By the time so at that point, of course, we went to fix his elbow, this terrible Triad. So I replaced the radial head and I had fixed the lateral structures at this point. And I apologize, I don't have these x-rays, but he had some mild subluxation of the ulnar humeral joint on the lateral. It stabilized in pronation, but this is somebody that I didn't think that it was necessary to go medial, but I didn't really trust him to stay in pronation for his rehab. So this is somebody that I put an IJS in just to give a little bit of extra stabilization because of his TBI and non-compliance because of that. He had immediate therapy in the hospital, and he didn't have a splint because he didn't keep it on ever. I took his IJS out at 3 months, which is what I typically do. They go to therapy the entire time. And at 6 months, his elbow range of motion was reasonable at 20 to 130 and 50 to 70. He started moving right away. So he didn't make any HO other than just a little bit right here on the medial side, probably where that medial ligament avulsed off of. Dr. Lawton, what would you do in this case? Or what do you do with these patients that have a bad TBI, high risk of HO, non-compliant with splinting because of that TBI?
Yeah, and that's the ideal patient for some type of supplemental fixation. Again, whether you want to go medial and then reinforce that I think either the IJS or an external fixator, because if you think about it, you're relying on, pronation and them keeping their elbow at 90, only taking it off to exercise. And like you said, you find it at the bedside when you go in to see them. So absolutely some type of supplemental, whatever your flavor of supplemental stability is.
Dr. Capo, what do you think?
Yeah, no, I would just add, especially with a TBI patient, somebody that might be a little, rammy, and IJS is better because it's inside and an X-fix is somewhat of a weapon, if they're in the ICU or if they're not, compliant. So I would do the IJS, and especially in that patient.
Great. I feel validated. All right. So my indications for an IJS are, of course, traditional use of residual instability after all of your bony stabilizers have been restored, and then after your lateral and medial side have been fixed. I do, like we talked about, if they're stable or just a little bit unstable after the lateral side is fixed in patients who have a TBI or cannot participate in therapy. I also use it if somebody had a prolonged dislocation or has tenuous fixation of either the bone, the radial head or the coronoid, or their ligamentous structures. And then I think controversial is its use in patients who have residual instability after the lateral side is fixed in providers who don't feel comfortable or want to go medial. I think this is pretty controversial still. I think probably the most important part of this is the therapy afterward. So this is our protocol, which are 7 days of a immobilization and a splint, typically in pronation or neutral. We then transition them to a brace. They get an active assisted elbow range of motion, including prosupination with the elbow at 90, and then a supine overhead extension protocol where gravity is at pushing the ulna against the humerus, and they're told to avoid varus stress for 3 months. We no longer use hinge elbow braces in these patients as it actually increases the forces across the elbow. So here are my take-home messages. So have a high suspicion for valgus posterior lateral rotatory instability and varus posterior medial rotatory instability, especially when they're coming into your office or the ED, not frankly dislocated. Take an algorithmic approach for fixation by fixing the radial head, coronoid, and then going to the LUCL, MCL, and then using an XFix or an IJS if needed. And IGS and XFix are not substitutes for ligament repair or reconstruction, and then appropriate rehab is paramount to success. And we use an overhead early active motion protocol. Thanks.
Excellent. Thank you, Nikki. So while Dr. Capo is bringing his talk up, especially as Nikki was going through that rehab, I did want to remind everyone that AO has a channel on YouTube, and sometime after 24 hours, this webinar will be available. So, if there's any specific points of Dr. Zelenski's rehab or the algorithm or anything that you want to refresh your memory, it's available there. We're also on OrthoTV, so thank you. Now I want to introduce John Capo, who's going to talk with us about treatment of the radial head fractures. John?
Great. Thanks, Jeff. You can hear me? I'm good?
Excellent.
Yes.
You're in fine voice.
Awesome. Thank you, my friend. Hey, I just want to add for the MCL approach, and I really like to go medial because you can see everything, and sometimes the ligaments flipped in there, even if you put an X-fix on. But for the coronoid approach, Bob Hotchkiss taught us this medial over the top. It's actually the strict medial over the top is very limiting because you come from the top. So I go right through the cubital tunnel bed, where the ulnar nerve is, and reflect the nerve, and then you're looking at the medial facet and the anterior coronoid. So you can put a medial plate on or an anterior plate, and then you can either transpose the nerve or just leave it there. So just a little bit different approach, and it's more extensile, and you can get anterior and medial. Okay, so radial head. All right, so the elbow joint, I think it's very important to look at this thing. When I was a resident, we didn't really, understand the elbow joint exactly, or the radial head, but it's 3 distinct joints, and the humeral trochlear joint is really crucial. You need that hinge that has to be reduced perfectly, or it's over, game over. Radiocapitellar joint is important. We used to think it was expendable years ago, the radial head. It's not expendable. And then don't forget about the PRUJ. The PRUJ is very important for articulation as well. So why is the radial head important, right? So the radiocapitellar is a joint that matters. There's an articulation there, and it matters. And it's we know it's the axial migration of the radius is a problem. So, the essex presti. So that's a big problem. So the radial head gives you a stable buttress to resist that. But there's also this posterior dislocation, and people don't realize that. If you have a little coronoid and a little radial head, or a common radial head, it's a problem, because the elbow wants to go out the back, right? The elbow wants to pop out the back, and that radial head can help you. If you have a coronoid fracture, you need a stable radial head to buttress that as well. So the bony anatomy, don't forget about this. So the anterior structures, again, the coronoid and the radial head are critical for anterior stability, because the elbow wants to pop out the back. The brachialis and the biceps, especially the brachialis, and the triceps are all pulling the elbow backwards. So it's that anterior buttress of the coronoid and the radial head that is critical. So that we need that, but also this medial facet. So if you look at the coronoid, Sean O'Driscoll taught us, it's not just a peak, it's not a tip. It's got these facets. So this medial facet is critical here, and it gives you that varus valgus instability somewhat. And the radial head is important as well. Okay, so other radial head stabilizers. Valgus stability, it's a secondary stabilizer, but especially if your MCL is out. All right, now this posterior lateral, that's the thing that we forget about. Posterior lateral rotatory instability, right? So if the radial head's out, the LCL's out, then the whole thing sags out the back. And it's not a dislocation, it's a rotation of the humerus, of the ulna on the humerus. So you'll see sagging of the joint. So let's talk about the radial head fractures. And it's all tied in to terrible triads, but I think it's, as Jeff said, we're going to deconstruct each piece. So the radial head, these are hard fractures, right? Because it's articular, it's hard to get to the other side. You can't do bicortical screws. So these are difficult, and they always look worse. This piece is sitting in the back, and that's the one that wants to fool you. So is it worth fixing these? Yes, right? And it's definitely worth. So these are some old papers. Bernie Morey was one of the founder or the fathers of elbow surgery from the Mayo Clinic. And, he looked at fixing this. ORF is the best results. And the native radial head, the native radial head is even better than a metal head. So a metallic radial head does well, but it's not the same as a normal radial head, because the radial head's not round. It's not, it's not spherical. And everybody's radial head's different. So does ORF of the radial head produce good results? If you do it well, yes, and you can get good stability. So this is the classic paper, and it's timely, Jeff, that we're doing the webinar now. It's 20 years ago, Jesse and David's paper from fixing these radial head fragments with multiple fragments. So their paper says greater than 3 fragments, right? So not 3, greater than 3, which I think is 4. 4 fragments, but it's an old paper, so they had bad techniques. They didn't have locking screws. They didn't have small plates. So greater than 3, 4 fragments. If they tried to fix them, they didn't do well. So Graham King, another father of elbow surgery up in Canada, looked at these, and if you can do anatomic reduction, stable fixation, early range of motion, they do well. So if we fix a radial head, I usually give us a time period. I say, let's spend 45 minutes on this thing, and if we can fix it, great. But at the end, if it's not stable and you can't range it, you got to get rid of it. So be honest with yourself, but try to fix it. On the other side is people say, well, I replaced them all. And I think that's wrong too. A 21-year-old, you don't want to replace it if you can fix it. So, but you don't want to do this because this is bad fixation, impingement, and it falls apart. So we don't want to do that. So this is a cadaver radial head from a study that we did years ago on fixation of radial head. So if you look at this, it's not, there's many things. It's offset, right? So the radial head is offset from the shaft. It's not 90 degrees. It's 10 or 15 degrees offset. So when you put your plate on, it might be angled, which is correct. Cancellous bone all the way across, so you can't get bicortical, and you have to be in this safe zone. But look at this carefully, right? Each facet is different, right? So the yellow is the PRUJ side. So it's flatter. So if the radial head's on the back table and you're looking at it, that helps you a little bit. And the lateral side is this angled side. So the head is not normal, nor it's not spherical. And I didn't even put this in here, even the dish within the head is offset differently on different people. So that's why a radial head replacement is difficult. And that's why the anatomic radial heads are very difficult to put in. And if they're off, it's a problem. So there's some papers that show that that's a problem. So this is the safe zone, right? And Bob Hotchkiss is very smart, smarter than me, but he makes it a little complicated. So basically, if you hold your elbow in neutral, the safe zone is straight lateral, plus or minus 50 degrees, 55 degrees, right? Because if you're in neutral, you don't want to put anything on the ulnar side or the medial side. So he talks about supination minus 50, pronation minus 50, whatever, but put it in the safe zone. So this is an older case of mine, and plating. So the goals, even with a normal plate, this is a 2-4 plate that I bent, but you want interfrag screws in the head, multiple screws to the head, low profile, and pre-contoured or contour it yourself. So this, and you can see the LCL was repaired. A lot of times, with these triads, they're all blown out. So you fix it and the approach is easy. But even if you fix just a radial head, if you're leaning on that LCL, your origin might be a little weak. So put an anchor in it. All right. So this is that case. Good fixation, multiple separate screws in the head. And this is before we had a little headless, but you can bury, if you don't have a headless, bury a headed screw if you want to get it off the articular surface. And this one, I think you can see my arrow. The radial nerve's right about here. So be careful as you bring that plate down. Look for it. And when you do your dissection, take your time. So different plates. It's not really the plate, it's the technique, but you can do a rim plate that goes all the way on the rim, but then that might rub, but that's okay if you need to do it. Or some of these neck plates are effective with angling the screws up into the head. So this is the technique if it's just a radial head, but I think it gives you the anatomy, because sometimes even when a Triad, it's not blown out. Unusual, but sometimes. So if you're going to approach the radial head, and this is, we've been saying this, I think Jeff and I have been saying this forever, the Coker approach, and this is one of those things that gets passed on forever. The Coker approach is terrible. And because the Coker approach is back here, and that's been propagated, and it's behind the LCL. Or you can sneak in front of it if you want to. And I remember I was in Europe at an AO course, and Ralph Hurdle, a famous guy who's very smart, does the Coker. I said, where's the LCL? He goes, well, I'm behind it. I'm in front of it. So you don't want to be back there. I don't think so. So this is the Kaplan approach, right? So you're in front of everything. So lateral epicondyle, go towards the radial head. So if the radial head's broken, I like to see the capitellum first. And you can see that the extensor mass, you reflect up, and then the supinator muscles, the fibers are almost 90 degrees. They're oblique to it. So that's when you slow down, when you see the supinator. So here you see the capitellum, and then you come down, and I think you can see my arrow. The nerve is about, about 3.2 centimeters from the tip of the radial head. So it's down here somewhere. If you just do screws, you don't have to see it, but you can see this is the supinator. But if you put a plate more than 3 screws, you want to see it. So keep your LCL origin intact if it's not blown out. And then at the end, again, because you're leaning on it, it might be loose, put an anchor in it. And then you get your radial head is down here and do your fixation. So fixing radial head fracture. This is a simple one. If it's a partial articular radial head and it's displaced, it's very easy because you just key it into the adjacent intact fracture. So people do well, and you don't need a plate. So this is a case, a younger person, interfrag screws, and really stable. And this patient did reasonably well, but not normal, right? Not exactly normal, but good results. So this is when it gets harder, when the whole head is off. And a lot of times this piece you see back here sometimes is in the back. And you say, where is it? And it's in the back underneath the tricep. So you look at this, and you look at this humeral ulnar joint line. And Jeff, you can see my arrow, correct?
Yep.
Fantastic. Yep. All right. So we used to think that if this is wide like this is a problem. But Graham King taught us that this medial humeral ulnar joint line is the key. So this is maybe a little wide, but this has to be parallel. If this is wide, it's not a problem, and it might be a little bit here, but it's this medial side of the humeral ulnar joint line that's critical to be lined up for instability. All right, so we looked at this years ago, and how many pieces are in the radial head? It's always worse than we think. We found it was like one more fragment and displaced more, so it's always worse than you think. And sometimes this is what you get. And this is a case of mine. We did this for about 45 minutes, and we said, all right, throw it in the bucket because this is not stable. Older case, so with a little bit of a bigger plate. This is a young patient, but even if you put this plate in the safe zone, it can impinge, right? So supination, it can impinge a little bit. Pronation, it can impinge, but this is where you need to put the plate. So I tell these patients when we do this case that the plate's going to come out, and 50% of the time it does. So, I think it's like anything else. You tell the patient and you give them, anticipation, or they know what's going on. So alternative fixation. If you can avoid a plate, there's some utility in that. This is Dan Rickley from Basel taught me this. If you can do screws, so a common radial head fracture, and you can see his humeral ulnar joint is lined up well, but this radial head's a problem. You need to fix it. So multiple screws, and I think Dan took off the epicondyle to get to it. I don't think you have to do that, and replaced it. But some key points in this fixation, right? Multiple screws, but if you can catch this far cortex on the radial neck, that really gives you stability and gives you kind of a tripod effect. So I think there's an old Mayo paper that looks at if you can just do screws, they have a little bit better result than a plate. But whatever you need to do that. So this is a case of mine, 17-year-old. I tried not to plate him, but you have to fix this. Pieces are all over the place. X-rays show comminuted. And sometimes you can get subtle shortening. If this radial head is comminuted, sometimes the radial shaft is short. So take a look at the DRUJ to make sure there's not an issue there. And we did small headless screws. We did 1.5 headless screws, and his LCL was loose. And you can see there's a little widening of this humeral ulnar joint, right? Because it hangs out and it rotates a little bit. And repaired that, and good result. And this is a nice lateral. And I wanted to, this is a key point. If you see the coronoid, and this is not a coronoid fracture, but some of these old diagrams they have x-rays or the, old diagrams from work. They say the olecranon is as high as the coronoid. It's not. The coronoid is about twice as high as the olecranon. So if you're looking to see, who cares, right? No, but if it's a comminuted coronoid, you can just judge how much is gone. So good result. He did well. We didn't have to take the hardware out. So radial head excision, let's talk about this. Basically, it's rarely. I haven't taken one out in 20 years, and I had an old case that somebody with post-traumatic arthrosis and instability. So it's got to be when would you take it out? Partial articular fragment, if it's less than 25% and it's a piece that's dust, I think you can take it out. If it's a piece you can fix it. If it's unreconstructible, but everything's got to be perfectly stable. And that's unusual, right? That's unusual that everything else is stable because, how does a radial head comminuted? It doesn't just explode. There's got to be some ligamentous instability. So very unusual just to excise it. And again, when I was a resident 20 years ago, we did excise them once in a while. All right, here's another case, 37-year-old dislocation. And you look at this, and the coronoid looks okay. Reduced her comminuted radial head, kind of like the case that Jeff showed, but I think her humeral ulnar joints are aligned. And she said she wants no artificial joints. And I've shown this case in other meetings, and everybody says, replace it, replace it, replace it. She's 37. So take your time and try to fix it, right? Because young patient, actually, this CAT scan doesn't help you that much, but her humeral ulnar joints aligned well. So what do? Close treatment, ORIF. So let me stop talking. So what, so Nikki, what would you do with this? Say it's 4 fragments. She's 37. Rest of her joints okay.
I would get my 3-5 loops on and my tiny screws. And she said she wants no artificial joint. So I think that you can always try. And if it fails later, do arthroplasty. So I would try to fix her.
Yeah, that's a good point. So try to fix it. And if it falls apart, then you have to replace it, right? But even if it's not perfect, there's a little collapse. And if it heals, people do okay. And even if I've had non-unions where the head stays there and people do all right, and it's like a biologic spacer. So yeah, I agree. And as we say in New Jersey, make it nice. Let's just make it nice. So we did that. And again, I've presented this at national meetings and everybody says, throw it away. So silicone doesn't work, right? No silicone, no closed treatment. This is, I think, the same picture from before, but you take your time, right? So it's not perfect, but it's pretty good, and again, look at this. The plate is not, it's parallel. What is that? Parallel to the radial head surface, but it angles down because the radial head is angled. And good overall alignment. The humeral ulnar joint looks okay. Her LCL we had to repair. Her joint is well aligned on the lateral. And post-op films, and 5 months later, and a little collapse maybe, but she's kept that for years, and I haven't taken it out. And with this plate so prominent, again, I tell people you might want this out. I have not had to take this one out, but I've found that if you take this out and they're stiff and you do a release, they get some results. Jeff, do you find that if you release these?
Yeah, I do. I think you do a little capsulectomy, and if you need to take it out, like you said, there's a little collapse, but functionally it's going to be stable, and she's happy with you that you saved her radial head.
Yep. And you can usually release them with maintaining the LCL. So she did well with reasonable results. Not normal, but good results. So newer implants, there's all kinds of implants. And again, it's not the implant, but this is an older case of a newer implant. This is an articular fracture. And this is one of the neck plates. So if you can stay off the lip, it helps. This is kind of a big plate. So I think a 2.0 or 2.4 is better. So in conclusion, the radial head is an important structure. So save the radial head, take your time, complex elbow fracture dislocations, and it really adds up. If you have a little cornoid and a little radial head, it's a big problem, right? So RAF arthroplasty is indicated. So whatever the arthroplasty, I think keep it simple, and I won't talk about that, but know your implants. And I think you need a modular because the neck and the head are mismatched in people. I don't think you cement it. And I like a non-anatomic because I know if I put it in, I know it's going to be centered and it'll rotate around the capitellum. So excision rarely done. So thank you very much.
Excellent. Thank you, John.
You bet. And I will stop sharing. Cool.
All right. And then next, Will Aibinder is going to talk with us about coronoid injuries associated with terrible triad elbow fracture dislocations. Thanks, Will. We see your slides. Perfect.
Great. Awesome. Thanks, Jeff. And so I'm going to talk about coronoids. And going last, I think this is one of the harder things, but definitely the thing we're addressing first through that algorithm that Nikki showed. So I'm going to go over some of the anatomy and the biomechanical data around coronoid fractures, briefly touch on some of the pathoanatomy, although that's already been touched on. We'll go over the classification systems here, some of the treatment indications, and the various fixation techniques. And I'm going to try to keep this focus on the terrible triads in particular. And so some form of this has already been discussed, but the ulnohumeral joint, there's static stabilizers, there's dynamic stabilizers, and then there's the bony stability. And the coronoid is very important, particularly as that anterior buttress, because most of the force of the biceps, brachialis, and triceps are pulling this posteriorly. And so you're going to get gapping potentially on either side. And so the way to think about the coronoid, for me at least, is that number one, it's an intra-articular structure. So you're going to have the capsule attaching distal to it, or onto part of it that might be avulsed. And so there's a capsular component to most of these injuries that I'll talk about. Most of us think of it as an anterior structure that acts as this buttress to a posterior dislocation. And so when you see this on a dislocation film, some bone superior here, you should be thinking about that coronoid fracture. And it's a nice way to see that opening angle that John was talking about between the olecranon and the coronoid. But it's also a medial structure where you're going to get some varus instability from the anteromedial facet fractures, but also if there's involvement of the sublime tubercle, this might play a valgus component from the MCL as well. And so how much coronoid can you accept to be fractured before you get some instability? And so there's a couple biomechanical studies that have been out there. So if you have more than 50% resection, you're going to get both posterior translation of the ulna and some varus instability. But to get this posterolateral rotatory instability that we're talking about, that truly is our terrible triad picture, just 30% injury plays a role here. So there are concomitant factors here. So the mechanisms of injury here. So PLRI, you're going to get your terrible triad injury, this picture Nikki had in her paper. And then these posterior impaction injuries, so the anterior radial head fracture and the coronoid fracture, where it's kind of a true shear force. You can get these types of injuries that present similarly. And then with PLRI, with the injury that progresses from lateral to medial, on the anterior side, you may just have an avulsion of the capsule, but some of that coronoid may come with it as well. And that's what we're going to really focus on here. And so historically, the classification of coronoid fractures was described by Regan and Mori. And so this is pretty simple based off of x-rays. So you're either going to have the tip of the tip, which is a type 1, less than 50% is a type 2, and more than 50% is a type 3. And these were subclassified into those with and without a dislocation. But O'Driscoll's kind of shown us in a more complex way how to understand these coronoid fractures. And this is where I think getting a CT scan on all terrible triads is important to really understand the coronoid that you're dealing with. And it helps demonstrate these injury patterns. And whenever we see this picture of this classification system, I think it becomes very daunting. And so to break it down similar to how we're doing this webinar, We have your type 1 fractures that can be subclassified into those that are less than 2 millimeters and more than 2 millimeters. And these are the tip fractures. So this is typically what we're talking about with terrible triad injuries. And then you have your type 2s that are the anteromedial fractures that have can have the rim plus a little bit of the tip, and then go all the way over to the sublime tubercle. So these are going to be more of that posteromedial rotatory instability. And then the type 3 large basal fractures that's sometimes seen in transolecranon fractures. So the other thing that I think is always important when we're thinking about fixing coronoid fractures is that there's a large cartilage thickness. So George Athwal and Graham King showed us that you can have up to almost 5 millimeters of cartilage on the tip of the coronoid. So even if it's a 2 millimeter fragment on a CT scan, it's going to look a lot bigger intraoperatively, but it's going to be harder to get fixed, still hard to get fixation into that large pace because it's mostly cartilage. And then when we think about coronoid fractures, it's important in terrible triads, we want to see what's the effect of concomitant injury. So a type 3 isolated coronoid fracture, which is quite rare, biomechanically from a valgus and rotational instability perspective is the same as a type 2 fracture with a radial head fracture. And then when we think about the collateral ligaments, type 2s and type 3s are essentially the same, even if you repair the LCL and the MCL. In this study, also done out of Graham King's lab, I think what's really important here is to understand the effect of pronation and supination, where supination is protective of the coronoid fracture. So if I get a really good repair of my LCL and I have a coronoid fracture, I might trust it in supination to protect that coronoid repair. And then we have our tiny fleck fractures, so these less than 10% fractures. This biomechanical study showed no difference between the native coronoid, those with that type 1 fracture, and when the fracture was repaired, irrespective of the ligament status. But I'd argue the study also does not account for any capsular injury that we'll sometimes see, leading to that some anterior subluxation. And so do all of these coronoid fractures need surgery? Well, Nikki talked about the study looking at non-operatively managed terrible triad injuries. And then Dean Soterianos also showed us that you don't have to fix a coronoid fracture if you address the radial head and LCL in most cases. So if you do have some type 1 and type 2 fractures with a stable radial head fracture, or one that you've addressed with a stable arc of motion and concentric reduction, then you could potentially treat those non-operatively. But the challenge, I think, with doing that is, as we discussed, fixing or not fixing your coronoid is typically one of the first steps if you're working from the lateral side. And so you have to make that decision early. And I think the size and location of the fracture, when we think about that Driscoll classification, is important. And one thing I do, and this is level 7 evidence, but if I can pass my index finger across my standard exposure, and I can get to the medial edge of the trochlea, to me, that's too much instability. So that I'd address whether it's the capsular avulsion or that little bit of a fleck. And then from a guidance perspective, from a biomechanically on whether or not to fix coronoid fractures, this is a great study also done out of Western Ontario, where they looked more at the anteromedial fractures, but just the isolated subtype 1, so just the rim, or the rim plus the tip, and they showed 5 millimeters is kind of the cutoff, where even if the LCL is repaired, you're going to get varus instability. And with the subtype 2s, you'll still get valgus instability. And so to me, 5 millimeters of bone with a small fleck, even if it extends medially, is something that I typically will go after to fix. I try as much as I can to do this from the lateral side, either resecting the radial head or sometimes supinating the radial head to dislocate and work anterior to it. And very rarely would I go medial. And to me, going medially really depends on what I'm doing. If I have to also do the MCL, sometimes I'll go through the floor of the cubital tunnel, or otherwise I sometimes will go through a flexor pronator split, just like I'm doing my Tommy John surgeries. So here's just a couple of case examples to show the various techniques and indications. So this is an older patient with a terrible triad injury, although about 4 millimeters is about 30% coronoid, but very common, very displaced, very osteoporotic. And so to me, this is one where I'm going to do a capsular repair essentially. So this is a non-absorbable number 2 suture that's been passed through the capsule that has some of the bone attached, and then I pass it through 2 drill holes. And you can see that being pulled down to the remnant coronoid that's left there. This is a younger patient, better bone. This is more of that posterior impaction injury, very unstable elbow that required multiple reduction in the emergency department by the residents. You could see it's quite larger and more significant from medial to lateral, but there's not a lot of bone to get good screw purchase across from it. So this is where I'm going to do a suture lasso technique. And so the first thing I'll do is try to get it provisionally reduced through the lateral side with a point of reduction forceps. And then I typically will drill two drill holes, one distal that's aimed medial. And I use two suture passers that are going through both fragments. So they're acting kind of like two K-wires, essentially, to keep the fracture reduced. So then I can take my reduction forceps off, and you can see the reduction of that coronoid is still maintained there. And so I find this easier than trying to fuss. And I don't like passing a suture and then drilling a second one, because I've had that suture rip at times when I've drilled through it, essentially. And then I'll pass one limb of that suture through the lateral drill hole to get that out of my way. And then leaving the needle on the other side of that to grab some capsule. This is me just making sure that that other suture passer is still through both fragments and there's been no displacement and we can see the edge of it. And then once we pass the needle through the capsule and have a purchase there, so the suture is going through the fragment and through the capsule, we'll pass it through the medial hole and then pass it back through down for our reduction. And so this is the control you have of that fragment. You can see as we're pulling on those sutures, getting it reduced very anatomically there. And so from a biomechanical standpoint, despite this, type 2 fractures, it's been shown that screws are stronger. However, the clinical studies still support using the suture lasso technique. You're going to get more stability, and there's no more implant complications with the screw and very little with the suture technique. And then this last case, this is one where you have a much larger fragment, much more unstable injury. And so typically I tend to try to use cannulated screws if possible, usually try to get 3 wires across. So as I'm drilling, it does not displace further. And so from a take-home perspective, I think coronary fractures are really important, rarely happen in isolation. So always be cognizant of associated injuries, whether in terrible triads or in these posterior medial rotatory instability cases. More than 30% involvement to me is highly suspicious of residual instability and something worth fixing. And even in terrible triads with that small fleck, I'd be always cautious about any capsular injury. An operative technique really depends on the fracture size and location. And the ultimate goal is to restore stability. Even if you don't get that fracture fragment anatomically, getting that some anterior buttress is really key. Thanks.
Excellent. Thanks, Will. So now we'll go back to that case that I introduced. And so remember, this is a woman that by the time I saw her, so middle-aged woman, now about a month out from this elbow fracture dislocation. So given the fact that by the time, we did surgery, so obviously radial head arthroplasty, as you see, you can see the ghost from the anterior capsular repair that I did. Nikki use a suture anchor. I tend to use through tunnels in the bone and tie it over the posterior humerus, but sort of potato. And then given that this was a repair, but a little bit of a subacute, I did stabilize her temporarily with an X-fix. As you see here, X-fix removal. It's easier to sort of see those tunnels there and the tunnels there that Will showed for the coronoid. And then here she is after and nice return of range of motion, both in flexion extension and forearm rotation. And she remained active, and I saw her a few years later when I fixed her scaphoid from another injury. So sort of a frequent flyer, nice woman. So again, we talked about all these things that we talked about, the radial head, treatment of the coronoid, treatment of the ligamentous. We've talked about, various forms of supplemental fixation. When I was a resident, we called these the silver arrows, the big Steinman pin. And I think just like John said, we want to avoid resecting the radial head. We also, ideally want to avoid the silver arrows. So I think we've given you a number of ways to address supplemental stability in terms of repairing the MCL, in terms of internal versus external fixators. This is a guy with an external fixator, and he was very active, and he was working out and doing his therapy, throwing beanbags, even with his X-Fix in place. The more modern internal fixation, but there's a number of different ways to provide stability, and I think it's important. So we've talked about that. I just wanted to, maybe run and present our panel with a couple of cases, get their thoughts on algorithms, and then what they might do in terms of supplemental fixation and then rehab programs. But the bottom line, when you're talking about these, the consensus, reading from Hotchkiss originally through Ring and Jupiter, Mike McKee, everyone wants to focus on concentric reduction of both the ulnar humeral and the radiocapitellar joints. Radial head, as John said, ORIF versus replace. In terms of the coronoid, some restoration of that if it's small, perhaps an anterior capsular repair. If it's a bigger coronoid injury, actually ORIF of the coronoid. And then your ligamentous structures, as Nikki showed us, in terms of LCL repair or reconstruct if it's late. And then MCL repair or external fixator. So John, this is a middle-aged woman, fell, injuring her elbow. Actually, let's see. I see John is, there's John. There we go. So, injured her elbow, but she has a history of this sort of non-specific injury in her 20s. And as she recalls, she was casted for 4 to 6 weeks. And here's the x-ray in your office that you see. So what do you think?
Should I talk now? Yeah. Something ain't right. I mean, something's not right. There's something, her humeral ulnar joint is not concentric. There's a little schnickel in there. Something's in there. And, her coronoid is blunted. And this is a perfect example. And I was going to interrupt Will. I don't want to, but you see all those line drawings of the proximal ulna? They have an arthritic olecranon tip. So they show them at the same, the coronoid and the olecranon at the same. And it's not. So this coronoid looks about the same height as the olecranon, but that's wrong because it's blunted. So that I think she's got it, and maybe she had an old injury, but her coronoid is missing, and it might be acute on chronic. And her radial head, something's wrong with it. And I'm worried about her. I get a CT. I'm worried about her humeral ulnar joint on the AP view, and something is off. So I think old coronoid, new coronoid, and radial. Yeah,
and as Nikki said in her talk very succinctly, you have to have your spidey sense about you. Because this is her x-ray when she presented to the ER, and she's got these films on her phone, but this isn't what you see in your office. And sort of John hit the nail on the head, or the radial head on the head, in that she's got this sort of old injury of her radial head, old injury of her coronoid, and it's probably associated with, her historic injury and then her new injury. So, okay, John, what are we going to do for her?
Can you give me some good imaging, Jeff, please?
So she's got, as you said, she's got a blunted coronoid and a blunted radial head.
Okay, can you go back to where I got one view, huh? You're busting me, huh? I got one view. All right, so I get a CT to see what's going on.
I agree.
She's 54, right? So hopefully she's not arthritic. I don't think she is. So I think you have to clean this joint out. And this is a good one. You have to do something with the radial head. Now, I'm worried if the radial head is arthritic and partially gone, you can clean out the joint. You can look at the radial head, and you probably have to go medial lateral. And if the coronoid is blunted and you're going to replace the radial head, take that piece of the radial head and use it as a graft on the coronoid. Because you're going to need something on the radial head. And if this is chronic, there's nothing there. So that's a nice technique. Jesse wrote that years ago, and I've done a couple. It doesn't fit perfectly, but it's a good buttress. So that's.
Yeah, I think it's a great thought. And I thought about that, anticipating that I wasn't going to be able to reconstruct her radial head and was going to have to replace it, and had that in my back pocket. As it turns out, her coronoid was stable just with the suture lasso technique that Will showed, with a couple of drill holes and using the anterior capsule as a buttress. But absolutely using that the part of the radial head that you osteotomize to replace a deficient coronoid is a great technique. And again, in her case, we did a lateral collateral reconstruction because I wasn't sure how acute the lateral collateral injury was. And there you see after the X-fix comes off, and it's her left elbow. So you see she's got a little bit of an extensor lag, but not terrible, and good flexion extension and good forearm rotation.
Yeah, it looks great. Jeff, just another thing just to throw out so everybody thinks about it. If your radial head is dust and you need a graft, you can actually take tip of the olecranon. You're going to take a lot of it because we know the olecranon really doesn't give you that much stability. But if you need 7 millimeters, you can take it from the olecranon and put it in the front, and it fits pretty well.
Excellent. Yeah. So, Will, middle-aged guy, ground level fall. This is his left elbow. Again, these are the x-rays, upon you meeting him. And the talk is about terrible Triad. So, not surprisingly, it was worse. And I didn't use the Spider-Man icon. I can't believe I missed an opportunity to use a Spider-Man in a talk. But, again, I think pattern recognition is important, and, Spidey sense is tingling, because this is what he really presented as with his elbow dislocation. But when you see him in the office, it's more subtle.
Right, exactly. And so, your dislocated films, you could see the coronoid. This one's pretty simple because you could see that triangular shape, but, some become a little bit more difficult, I think, when you see them in the OR, in the clinic, especially if they spin back around, so you don't have that coronoid tip appearance. So looking at that opening angle and blunting is helpful. The radial head doesn't look awful here. But as John kind of told us, it always looks worse. So I think getting a CT scan here, is still helpful. I mean, for me, I get a CT scan on everybody, but definitely thinking surgery and going through that algorithm is kind of the next step in discussing this with the patient.
Absolutely. And wouldn't you know it?
Jeff, let me just take a guess. So I think the medial facet, if you look at your reduced film, that medial facet looks a little wrong. Right. So I just want to make a point that you see over there something, maybe not, but there, there's the coronoid, like, Will showed us nicely. It's not just a pyramid. So there could be a tip fracture and a medial facet. So you might have to go get those differently. So,
agreed.
Yep.
So as John mentioned in the last case, and Nikki and Will brought up, imaging. And I was worried about the medial facet of the coronoid, as John brought up. As it turns out, imaging through there showed that was not an issue, and it was more the tip. But you can see this comminuted radial head, and I think Will made the statement he gets CTs on all of them, and I would say I certainly get CTs on most, because it helps me have an idea of what I'm going to do with the radial head, what I'm going to do with the coronoid. So I think it's very helpful for preoperative planning. So in his case, again, John, I was worried about that, the medial aspect of the coronoid, but I think it was just projection, because the CT and then a better view shows that medial aspect of his coronoid is okay. You can see the ghosts from the capsular repair, and then get him moving early, as Nikki said, with a rehab program, and then pretty good result.
Dr. Lawton, can you go back and can you go over your technique for how you get the suture fixation of that coronoid? Because that's like a beautiful reduction. Mine never look like that. They're like,
so Will sort of showed it. I do it. I don't do it as open. So I'm coming through lateral approach, and what I do is I pass 2.62K wires percutaneously, the subcutaneous border of the ulna, and then I'm looking if I've removed my radial head. I have, like just like an Army Navy, or a Bennett retractor in the front. So I'm looking at the base of that coronoid fracture, and I'm watching my 2K wires come out. And then I sequentially, and then I'll just make a small incision, 1/2-inch incision down the subcutaneous border of the ulna, and pass a couple of Houston suture passers, as Will said. Pass each one individually, grasp that anterior capsule, and then pull it down. And it's, as Will said, you sort of, have to make a decision on the coronoid, because it's sort of the first thing you got to do. So, my order of operations is usually, do something with the radial head, whether I'm going to, repair it or replace it. Through that, then address my coronoid, have my sutures ready to go on a hemostat, have my lateral collateral sutures, as you showed, ready to go on a hemostat, then replace the radial head, and then tie everything. If that makes sense.
Yeah, you really have to go from deep to superficial, right? And you really have to think about it, as Jeff and Nikki are alluding to, like what you tie down. Like, you don't want to tie down this coronoid suture before you replace your radial head and your LCL, because you're closing the book. So you get it all set, put your radial head in, get your LCL sutures ready, tie it down, pronate, they do the LCLs. They really have to take your time and think about sequences, as Dr. Lawton's saying.
Yeah, it's sort of an outside in, inside out. And then you can go through, and it makes for a real nice demonstration that, whatever you have with your radial head, and then I'll sort of tension, I'll just put a cross on my suture and show, get a fluoro image, as you mentioned, Nikki, that perfect lateral image, what it looks like with the anterior capsule repaired. And that serves as a nice buttress, but it doesn't restore that stability. And then you tend to still get the opening of the medial trochlear clear space. And then go ahead and tension the suture on my repair. You mentioned using a suture anchor that you can slide. I tend to do it through 2 drill holes. And again, I sort of cross the suture, and then you can sort of tension that and demonstrate how your stability is going to be. But it's sort of planning, as Will said, in terms of order of operations, how you're going to address things.
And one other just little technical point. I do the same thing you do, Jeff, kind of provisionally set everything up. But that the timing to tie everything, I think it's really important to make sure you have it reduced. And so for everyone on the webinar, doing it, putting the patient in that overhead position across their body, that helps reduce the elbow. And then I tie that from the coronoid or capsular repair first, and then go to the LCL repair.
Yep, I do the exact same. Excellent. Well, we're right on time. I do want to remind everyone about upcoming webinars that AO is putting on for acute scaphoid fracture, finger flaps, both bone forearm fracture, and distal radius malunion, a few in-person classes. And again, thank you everyone for your attention and participation. Thank you, Nikki. Thank you, Will. Thank you, John. Thanks, Mackenzie and Abby. Good night, everyone.